What is the difference between a corporate sector anesthetist and a private sector Shital? I mean, what would be the major difference?
I think in a corporate hospital, you have somebody else around you to help you in terms of unexpected crisis. Anesthesia, I feel, is always smooth sailing till when a crisis occurs, and
Till
it
a sudden
always
event
occurs
happens.
suddenly. You know, when I am in the OT here or anywhere else, or when Dr. Mishra is there, I am the whole and soul of that person. So I better be observant, I better be quick, I better have things and equipment ready just for safety's sake.
But that's true in corporate.
But if I call someone for help, there
They will
won't be
only-
any other
Yeah.
anesthetist to help me around.
So you'll have more
Untrained,
support.
yes, I feel that is a huge disadvantage in the private sector.
Welcome to our fifth episode of Consultants on Couch. Thank you once again for liking, subscribing, and for our episodes. This episode is very episode which is very close to our heart. I'm introducing two doctors with whom I spend most of the time in the operation theatre, and very interesting people, very dedicated, hardworking, and I think anesthetists are very clever people, much cleverer than surgeons, orthopods, gynecologists. I'm going to introduce Dr. Pramod Mishra and Dr. Shital Maniar, who are anesthesiologists Sujay, and they've been working with us for almost a decade or more so. Dr. Mishra has studied in Orissa. He's had his anesthesia training at AIMS at Ashwini in Bombay in Kolaba. After that, he's worked in Delhi for some time. In Maulana Azad and AIMS, Ram Manoram. Mishra ji, I don't know much about that. And after that, he's been working in the private sector as a very senior anesthetist. He's very good at his work, and it's a pleasure to just have him work on a patient. It's fun to talk to him. All patients will love him. Dr. Shital Maniar is from Sion Hospital. She's done a undergraduate at Nair and done an anesthesia training at Sion Hospital and the esteemed Tata Hospital, where she's sort of worked on very critical, difficult onco patients. She's been in private for over a decade now, and she comes to Sujay. She's very popular with the gynecologists, the orthopods, and with the patients. So welcome both of you all together. The reason we are doing two doctors this time is that most of the questions are going to be anesthesia driven, which have become very cliche. But since I work with both of you all together, I said might as well have two anesthetists together, and they can gossip, which we are all very good at. And anesthetists are known for passing information. They are in the IT age. They're more modern than we are.
We only volunteer information when asked. So let that be clear.
Who
All
doesn't
surgeons
know?
ask us the information and we
No,
choose
is it
whom
true?
to tell, whom to not tell, or what.
Is it true or not? I mean, anesthetists love to gossip, Mishra ji. What do you think?
No.
I don't think
We
that.
love to listen to gossip.
So, Mishra ji, let's start with you. I mean, you've studied in Orissa,
That's it.
and that's where you did your undergraduate,
That's it.
and post graduation was at Ashwini. Ashwini, I think most people would not know that it's a Navy hospital and it has a medical college.
No, it's actually a command hospital.
Okay.
So all the sailors and the families, the officers of the Navy, they get admitted there. They get referred from all over the place,
Okay.
and they come to Ashwini. That's the largest command hospital. It's about 850 beds.
Oh, I didn't know that. And it's a tertiary hospital with cardiac,
Yes,
everything.
everything. So, incidentally, I was born in Ashwini.
Oh,
I spent my schooling days in Kulaba.
oh, nice.
So, my dad was in the Navy.
Okay.
But then at that time, I did not have a domicile of Maharashtra.
So,
So, I had to go back to Orissa to do my.
Oh, that's interesting. So when you were born in Ashwini, you know, and then you did your post graduation. I mean, come on, how coincidental is that?
So incidentally, during my post graduation, my bosses were all students of my father. And they kept telling me that you're just not like your father.
So let me just tell them, your father was in the Navy as
My
well?
father was in the Navy, he was on the administration side of the hospital.
Okay.
So he was the first officer.
And he wasn't a doctor?
He wasn't a doctor.
So what made you, or what made him to whip
No,
you to become a doctor?
He didn't push me into anything.
Okay.
It's just that I wanted to be.
And what was the reason for that?
Maybe I felt a lot more empathetic towards pain and suffering.
Okay. And you were good in studies?
I guess so.
Shital, your father's a doctor. And
Both my parents are doctors.
I didn't know your mother was a doctor.
My mother is also a doctor. She's from Nair Institute.
Oh, that's nice. So Shital's father is one of the very senior pediatricians practicing in Malar, and he's been in UK and a lot of sort of.
So
he was very British till the end,
Very.
having his scotch till the end. So
Absolutely.
your sister's a doctor. Your
Yeah, so my whole family is a family of doctors.
brother-in-law's a doctor.
Yes.
So why did you not marry a doctor?
I think they were more than enough.
Okay.
Doctors in the house.
So was it some
I
kind of family
wasn't-
thing that you would become a doctor? Was
I think it was I never knew another life.
Absolutely.
Both my parents were doctors. The conversation in my house was always about medicine or some patient. My father's friends were all doctors, as generally doctors tend to mingle amongst themselves. My mother's friends were all doctors. So the people
you
I
just
met
born
around
and
in
brought
my
up
social
trying to become a
circle was
doctor.
were doctors. So I think it was.
And you did your undergraduate at
From Nair.
From Nair Hospital.
And then I went for my postgrad to Sam.
What's there? So I'm a Nairite. Okay.
Yeah.
And can you tell us some bad things about when you did your sign, when you went to sign? Something wasn't as good as Nair is.
So in
always.
Nair, we were like happy, chirpy, three birds wandering about. And when you went to San, it was like a culture shock. The language was only and only in Marathi, even amongst doctors and among staff, and it was a very depressing place, located in a place, flooding
And traveling is
and
not
traveling
straight.
through Dharavi to reach the hospital. So there was
But
nothing
it's-
great about
it's-
going to San.
But it's a beautiful hospital in terms of medical facilities,
I
in
think
terms of
it's a very heavy. The
Heavy.
workload is extreme. We had many people from Delhi who would come over with that aim from from the All India entrance. It was very hard for them to cope with the pace, because everybody in San was very fast in everything you do, simply because there was always a line of patients waiting. So if you were slow, it was frowned upon. You better be quick.
I had this conversation with Samir, and
Right.
how all of us are, at least in Bombay, very territorial about our own hospital. Nair, yes, then everything's good at Nair. But
No,
I've
but
been,
let me tell you an incident about Sion Hospital. One of my juniors, she had just taken admission in anesthesia department in
Okay.
Sion. And the first day,
gave up, I
she
think.
was found collapsed in the chimney. It was so heavy.
it's a very busy place.
Oh,
I mean,
very.
the training is brilliant. I think
Absolutely.
most.
I think it's the
most
volume is
cyanide,
so
yeah,
much.
volume is so much,
Nothing.
and
Volume, you do the same thing over and over and over. I think.
so when I joined MBBS, we had choices. The first would always be KEM, and then depending
Correct.
upon our marks, we would go. My second choice was Science.
Okay.
No, my second choice was Nair, but I got into Science. So I went there for a day, and there no direct
Correct.
connection from the suburbs to Science. We had to change buses and stuff. And then suddenly one vacancy opened up at Nair, so I changed to Nair. So I could have been both, Science and Nair. So what made you become an anesthetist after MBBS?
Actually, I'll tell you, I didn't really. The reason starts from I became a doctor. I just got the marks and I went into it. I became an anesthetist. I think I had lots of friends in anesthesia. Some of my sister's friends were doing anesthesia, and they were all they were also incidentally at Sign, and they were like, "Come." I mean, I didn't really put a lot of thought into it.
So what is the difference is why I like this is because this is what kind of conversation, and we are honest. Otherwise, on camera, would have, I always dedicated my life to anesthesia. I wanted to do some good for patients and stuff. So anesthesia was just something that
That
happened.
happened to me. And once I entered anesthesia,
Then you started loving it.
then I started. Actually, I first fell in love. I mean, the first thing that I liked in science was the E ward. They had a trauma ward. It was very happening. It was very
Full
active,
action.
full of action, and like actually. So I think I found that extremely interesting.
So adrenaline and
Yeah,
super.
yeah.
Anesthesia is.
It was a quick place. You come quickly. Somebody is half dying, brought from the road or whatever. It was very interesting to watch that and then learn that and then do that.
Great. Mishra ji, why did you do anesthesia?
Oh, I just slid into anesthesia. Actually, I
Same.
never wanted to.
You never wanted to become
I
a
never
doctor?
wanted to be an anesthetist. I wanted to be a gynecologist.
Oh, wow.
So much so that during my MBBS
But one
days-
thing, he'll make a very good gynecologist, actually.
that
Mishra ji. I think you'll make a good gynecologist.
during my MBBS days, during the holidays, I'd gone to Gandhinagar in Gujarat. And that was the time the residents were on strike.
Oh.
So one of my brother's friends, he was the only specialist in the civil hospital in Gandhinagar.
Oh, wow.
And since I was interested, I used to go there and sit with her in the OPDs, and in the OTs. And I was really fascinated by obstetrics.
That's
But
the
then
one thing I
gynecologist-
never liked obstetrics.
But then why anesthesia?
Because I shifted to Delhi from Bombay because of my daughter. She was an asthmatic.
Oh.
So the pediatrician said this, it's the weather that is causing other problems. You go somewhere, try.
Oh.
So I went to Delhi, and at that time there was more of a chance in anesthesia than in obs, because North India, they
So
don't
you,
want.
you did your post graduation from
I did it from Ashwini. I came back and I did it from Ashwini.
you did your anesthesia post in
Yeah.
Delhi, then you came back and got registered for MD in Ashwini. So after Ashwini, is there a difference in working in Ashwini and then coming to private practice? What was the difference? What do you start? See, when we started, I mean, I think you and me are contemporary. She was a little bit younger. Technology has changed in anesthesia drastically.
Drastically.
I know we used to just shout out in Nair Hospital when we were there. We would know oxygenation by the color of blood. You remember? I mean, say, "Arey, iska thoda khoon is black." I mean, obviously we had pulse oximeters, but the basic assessment was, oxygenated the patient was color of blood. What do you think has changed in
So
anesthesia?
plenty,
in terms
because
of
when I
technology?
started anesthesia, we were still giving some patients ether,
Yes.
which is which is like really ancient.
Shimmel Bush
Shimmel Bush mask.
mask.
I have one of those.
So I've only seen one of those in the anesthesia museum.
Yes.
I have never ever seen anyone
So
use it.
I have used it also,
Oh wow.
and we didn't have any
Exam
monitors.
question. What it
Yes,
is.
yes. That's how I know the name,
We
being a
didn't have
surgeon
any
also. Yeah.
monitors. No cardiac monitors, no pulse oximeters, nothing. So we were taught a cycle. You start with the IV bottle, the rate, you'll see the. Oh, by the way, we didn't have vein flow, so we used the needles of the IV set. And
Krishna, how old are you? I mean, seriously.
That's really
No,
ancient.
no, but seriously. So what he's saying is that technology has not changed over decades or something. It just changed very rapidly.
rapidly.
I think in 10 years' time, when I speak to my son and I tell him about, so medical technology has changed and it's changing. When I talk to my son, who's a surgeon, and I tell him, we used to do this. Oh, what age? What age? How old are you? He asked me the same question. Never heard of it. How old are you, Paul? So now, what do you feel? I mean,
now it's
is
much
AI
easier.
and robotics will come in anesthesia?
Now anesthesia
Absolutely.
is much more easier than what it was at that time,
Mm.
because we had no aids. It was our eyes, our ears, and our knowledge.
Do you think that makes him a better anesthetist than
I
I
actually don't think so. I did my residency in science. Then I did a 1-year lecturership.
I'm not saying he's better than you,
No,
but
then I
doesn't
moved to
make-
Tata. So when I came into private practice, I saw all these people roaming around with just that finger probe pulse ox. but I was not good enough. I was incapable of doing that. So I actually bought my multi-para monitor by
Go around.
myself at that time.
And you would go around to
And I would
places.
lug it
No,
around
that's because you
everywhere.
were used to working with that. No?
Yeah, absolutely.
No, but
So
it's
I,
safer.
I
is safer,
couldn't
much
imagine
safer, of
working
course.
without that.
Of course, that's what I said. Now it is much more safer, much more efficient.
So, do you either of you now train juniors, or are you involved with any sort of training?
Not
Would it be
really.
easier to train now than what your teachers trained you and stuff? Or?
I think
No, I don't think so. I don't think so.
No, I think technology helps in training.
No, I don't think so, because what it does take away from the junior doctors is the ability to think out of the box. So here you have a set of monitors, you have a set of parameters, and you're following that. You're not using your brains about why something is happening. So I think we've lost out on that.
Okay. So, I believe both of you are now exclusively work in private setup, or you all go to any government places to sort of. What made you sort of? There are corporate hospitals where the facilities are A grade and you didn't have to lug your monitor around, and general private. Now most private sectors have almost everything.
I think now every place has everything.
So we've had this forever.
Yeah,
And,
yeah.
what is the difference between a corporate sector anesthetist and a private sector Shitu? I mean, what would be the major difference?
I think in a corporate hospital, you have somebody else around you to help you in terms of unexpected crisis. Anesthesia, I feel, is always smooth sailing till when a crisis occurs, and
Till
it
a sudden
always
event
occurs
happens.
suddenly. You know, when I am in the OT here or anywhere else, or when Dr. Mishra is there, I am the whole and soul of that person. So I better be observant, I better be quick, I better have things and equipment ready just for safety's sake.
But that's true in corporate.
But if I call someone for help, there won't be any other anesthetist to help me around.
So you
Untrained. Yes. I feel that is a huge disadvantage in the private sector.
So, in the various sort of privates that you worked with, and there must be some incidents. I know Mishra ji and we talk, and I know a lot of his incidents. That's why I'm asking him. What was the scariest incident of anesthesia you had in your career? And what happened? I mean, I don't want you to sort of
So my
scare the
scariest
viewers or
no,
something,
not
but what
like
happened
that,
in terms of
you know, just giving some general anesthetic and the patient goes under, and before you can do anything, he vomits.
so vomiting is
Vomiting is one big scare for me.
okay. But Mishra, you are aware that now with the new ERA's guidelines and early recovery from surgery, that you're not supposed to starve them what we used to overnight. 2 hours is the maximum.
2 hours
that
is
is to
for
clear
clean
fluid.
clear fluids.
Clear fluid.
Sugary fluid.
No,
No, not sugar.
Not
Clear fluid.
Happy.
Happy. That is
Yeah,
without
sugar.
fiber. When I say sugar, I mean without fiber. Tea, which is green tea, or something which is clear and transparent to look at.
So what I must tell the viewers that anesthesia is one branch where they have to have knowledge of almost all parts of medicine. And here you've got this patient who's been sort of sedated, you controlling the respiration, the cardiac system. So I think anesthesia, they know surgery. I mean, they would know what is happening. They would understand orthopedics. They will know gynec, because most of the places you're going to be helping with the baby also.
That's right.
Sometimes neonatology
Most of the time you're resuscitating
the baby. You should know your heart, your medicines and stuff. I think the study for an anesthetist is generally much more than. Do your books sort of are probably more extensive than for surgeons is limited, orthopedic limited.
No, for I think just administration of anesthesia is a fairly technical job and an easy job.
Absolutely.
It is how your anesthesia is going to affect the person. That is the difficult thing, because you have patients who have got diabetes, blood pressure, heart disease. So how my anesthesia?
A lot of variables are
A
anesthesia.
lot of variables
So we
and,
have to know all that.
and obesity. I think the amount of obese people that we see, I don't think is multiplied by 10. As when I started my practice, I can tell you there was hardly anyone who was obese. But now I feel it's the
very true.
norm. Like there's so many.
If we were to do a study of how many overweight patients we are dealing now, I think almost 50-60% is fat
Definitely,
obese.
definitely.
At least 50 to
And all of us
60%.
have trained in, you know, government, semi-government hospitals.
Where everybody's thin.
Where everybody's
There was no, there were no fat patients. Our surgical patients used to be so small, no obesity and stuff. So for me, anesthesia, we basically when you put somebody out, can you explain how does anesthesia, how much? So for most people, no, anesthesia means general anesthesia. Or talking
Most
about.
people like also general anesthesia.
But
Most people
so what
don't
is
want
anesthesia?
also
You
anything.
can just let them know what does anesthesia involve and how does anesthesia work. I mean, what is anesthesia?
Okay, so anesthesia is when I give you a medicine which penetrates there's a barrier, there's a blood-brain barrier which penetrates in your brain and makes you lose consciousness.
Okay.
So it's not similar to deep sleep, as in if you're sleeping deeply, you might still, wake up to, if I prick you with a needle, you'll wake up immediately. So the exact process of how certain drugs cause that change in the brain is still not known.
Okay.
You just know that there is an interplay with certain neurotransmitters, GABA, you you'll sort of antagonize it, and you will go to sleep.
So
And you'll be
you say it's still
unconscious
not
in
known?
no, so at the
Yeah.
deep molecular level, they still don't know why it happens, how it happens.
That's because your consciousness is still not defined, no, in actual terms. So when you lose consciousness, so there is lot more to anesthesia than general anesthesia. It's
Of course,
Of
the
course.
local,
regional
regional.
anesthesia.
But for regional and local, I think there's a particular mechanism of action that you know what happens.
Yeah.
When you give this drug, certain iron pumps stop working, the cell doesn't penetrate to stimulate. So you know that. But I think the mystery is in general anesthesia. In fact, one of our general anesthetic drugs is now, it's one of the oldest drugs, ketamine, is now actually being used to treat depression as a therapeutic treatment. Like people have come out of depression using low dose ketamine. Yeah.
So obviously there are conscious altering experiences with that. I've never taken general anesthesia, but have you come across any patient, Mishra, where they've had this out of the body? So there's something called awareness in anesthesia, general anesthesia, but I'm not talking about awareness.
Right.
I'm talking about conscious uplifting, any philosophical. I'm talking about spirituality. Because LSD, some of the drugs,
Right.
your even formatted ketamine and stuff, they are consciousness altering or increasing your plane of consciousness to a higher level. Do you come across the patients who say, "Oh, doc,
Yeah.
no, I've just
been
seen
told-
Nirvana," or
I've been told by patients, doc, next time I have a rave party, I'm going to call you.
I know the patient.
Yeah, it was
Can I have Mishraji's number? I go, why do you want Mishraji's number? No, I'm going to get called to a rave party. But has anybody come and told you, that they had some higher level of consciousness?
Not at all, actually. Most
But-
people will tell you that they feel like they've had 5 glasses of wine and are feeling happily buzzed. That's the word.
But you also give them some medicine to forget their experience?
Some of our medicines
Some of our medicines are like that they produce a sort of amnesia which is going to happen. Right? It's called anterograde amnesia. So,
Obviously, the drugs that you use are narcotics.
yes.
And there is a higher incidence of addictions in anesthetists, and there are habitual you sort of.
That's because it's so easily available to us.
Okay.
And sometimes the pressures of work, they're too much for some people, and they have easy access to it.
Okay.
There's a lot of affiliation.
As a female anesthetist mother, were you worried when you were pregnant to be anesthetist? Because there's a lot of talk about
Yes, absolutely.
inhalers and stuff. So,
So
were you working in your pregnancy?
I was for both.
Okay. And
So yeah, so the certain gases are said to be teratogenic, like they harm your child.
exactly.
Yeah, so when luckily for me, the first time I was in an institute, so I transferred myself to the ICU. So I didn't wasn't really in the operation theater for the first 3 months. I was at Tata, so I voluntarily moved to the ICU. People were more than happy to change their things with me.
But ICU, then you wouldn't be exposed to
I would be
Gases.
exposed to
gases.
anesthetic gases,
Yes.
and I had to be careful when X-rays and all were being shot. So,
Okay. But
yes.
otherwise,
But yeah, there were diseased people everywhere around me. But then I mean,
that's a
it's
job.
part of this my
The
job.
problem of being a doctor.
How was it working in Tata Hospital? Was it sort of very
So I
different?
came from
And
a
how did
place
you
of
land up in Tata?
poverty, like in science you had to arrange for everything. Nothing was easily
Yeah, I
available.
know.
To a place of plenty, where you ask for something and like it's right there. So and even anesthesia wise, you would think there's nothing new to learn in Tata, but there's a certain protocol set in Tata. So things are done. So there's a lot of evidence-based medicine. So they will not just do anything randomly
Much
without
more
reason.
modern than
Absolutely, and then teach you how actually to approach an airway, because I think India the highest number of cases are all oral cancers. They invade your tongue, mouth now.
And
So
then to
that's a
give them
little
anesthesia is more difficult.
more difficult because their airway is not accessible. So I think they teach you, I mean, how to manage that. That is the predominant thing I learned. Also, Tata has a wonderful ICU which is managed by the anesthetists.
Okay.
So they are the boss of that ICU. There is
So, one thing I think so anesthetists in a foreign country, I mean developed countries, and anesthetists over here,
right.
there is a very large difference.
Yes.
Not in terms of what you'll do, but in terms of
The
they
economics.
manage. No, economics is one. And that I'm coming to that. Why the economics? Because the anesthetist in a foreign country
Correct.
is actually looking after intensive care, looking
Right.
after access, looking after casualty, looking after investigations, managing pain clinic, which is a very so one thing anesthetists do is manage pain,
Correct.
on long term. And now we have pain anesthetists.
Yes. So there's a specialization in pain.
specialization
So now there is a critical care.
and critical care,
Yeah,
intensive care and stuff. So the other thing is that lot of the anesthetic actual work which people do here has been taken over by anesthetic assistants. So I've got a friend who manages
Yes.
6 ward rooms, and
Right.
he's the sole anesthetist.
So I have some anesthesia technicians who have been training. They can do everything because they don't know why they're doing it.
So
They
that's
can
what
know.
you mean.
They know how.
So
to
you are the supervisor.
Yeah.
But you train them and
Yes.
you get involved with training
Yes.
anesthesia and stuff.
OT technicians, my anesthesia technician, I'm involved in training this thing. Every day I'm asking them questions, trying to get them to think.
Exactly.
So,
On
On
coming
the
back to
same
the-
thought, I think if I was undergoing anesthesia, I would like my anesthetist to be present throughout the surgery, before, during, and after. I would not like myself to be handed over to a technician who's not even a doctor. So I actually strongly object
So-
to this. I understand that.
So most of those things are economic driven.
Yeah, absolutely.
Over here, so coming back to here, over here in a team, you think the anesthetists are exploited, underpaid? Is that something
absolutely.
that definitely?
I mean, yeah, I do think so.
Is that because they are not involved in sort of over here the patient contact is with a consultant or a hospital, or you're following up and stuff, or is it just economics of the whole thing and they're not sort of
no, see, the patient is primarily seen by the operating person, which is the surgeon or the gynecologist or the orthopedic surgeon. The anesthetist is not involved in it at all. He sees the patient on the when the patient comes into the operating room. So that rapport, that understanding of
the finances are not arranged.
the finances are also not known to us. We, I mean, 100% of the time we don't know what the charges are going to be. So some hospitals have fixed charges, Some hospitals have variable charges. And the surgeon is the person who knows best about the patient. So we leave it to them. And I prefer working with people
Whom you know.
whom I know, whom I know that they're not going to uh, pay me a pittance while they take a large job.
But generally, as a group of, I mean, as a senior anesthetist now, both of you all have a lot of junior anesthetists who know each other in group. So, what is one advice you tell them to sort of be aware of that exploitation that goes on in anesthesia, or how can you be aware? What can be done? A lot of group practice is happening.
Yeah.
Right.
And
So for junior, I would only say that trust your instinct. If you feel there is something not quite right about the patient or is not quite, be firm in your no. Say no.
Say no. Saying no. It's the very feminist thing, no? It comes from that. No, I agree. What I mean is that's a statement, but I didn't just edit that. I don't want that to come. But it's that say no. No is a big thing.
But learn to trust your instinct.
Yeah, I agree with you. I think
sometimes when you see a patient, maybe after many years of practice, one little voice
instinct has come.
says to you.
No, I've seen. We work, all of us when we work, and we know that way. Sometimes Madam has said nahi karne ka hai, then you will say, let me just not do him right now. Go and get this test done, and we always are wiser, because we don't want to get into.
So there have been times when I have said no, and the surgeon says why and all that, and the patient has gone into the ICU the next day.
So that's very.
So that's something that I think when you've been working for so long, you tend to pick up from when you see the patient.
So, what is it about the operation theatre that you like the most, Mishra? I mean, all of us. I know we get, if you don't go to the OT once a day.
Same. I like there's teamwork. It's a teamwork. Every single person contributes something.
Happening and stuff. And do you ever get feedbacks from your because you guys are not on the clinical side, and very few times you get. So now, at least now, we do pre-operative checkups, and it's mandatory by guidelines that you see a patient, counsel them, talk to them, anesthesia consent is taken in much better way than what we used to.
I agree.
But as a doctor, both of you, do you ever feel that, it's less of patient, less of a doctor, because you're not communicating? Like your father was, more of a doctor than you are. Absolutely. Or your mother was more of a doctor than you are. Or,
most of the doctors in the clinical practice, they deal with the entire families.
Yes.
Not just one patient. Whereas we are restricted to that. During the course of the operation, if the patient is not given general anesthesia, given regional or spinal anesthesia, they talk to us.
Yes.
Yeah. We just kill quite a bit.
Yeah, that we do. But
that is the only time.
But then, two patients really, how many of your patients they come back to you and then they sort of
I think some of our patients do remember to come with
remember. I know I sent one of them old person who wanted to come and meet you.
It's actually quite a lot of patients.
What percentage?
10, 15, 20?
Maybe 10%.
10%.
Some people actually come and say with the other family members that you were there for me.
Yeah.
This is my daughter or this is
that
my
is
son.
because you working now in one area,
so
one place, and then you see.
So this last month we did one fracture over here, and the father later on was a 14-year-old boy. So the father said, "You're Dr. Mishra, no?" I said, "Yes." He said, "When this boy was 2 years old, that time you'd given him anesthesia."
That's satisfying. That's what.
I remember my name.
But also maybe it's our fault because honest to God, I don't remember.
You don't remember your patients?
No, I'm sorry to say.
I think it's
also because the interaction is transient,
Yeah, interaction transient. And half the time they sedate.
And most of the time we're seeing them lying down.
We don't actually see and when we look at them also, we'll probably look at them and think airway. So I don't really, I'm probably thinking, okay, thin neck, thick neck, whatever, IV line, is the hand. Also, when I look
Yeah,
at
so
a
I think
patient, I don't
as
actually look at
as a
them.
reflex, the first thing that when they meet somebody, you look at the IV.
IV access है तुम्हें पड़ेगा.
And a reflex actually.
So when your patients come down the surgical bench, we
Usually
actually,
looking at the arm.
I don't actually look at the patients like that. I'm actually looking at her airway. I'm looking at her mouth opening, or I'm looking whether she has a thick neck or what. I'm not actually looking at
You're
her.
trained to do that.
Yeah.
Isn't it? So you got two kids and one son.
One son, one daughter.
One daughter. And your husband is on the corporate side,
Right.
management and stuff.
Absolutely.
How easy is having a non sort of doctor as a husband? Do they understand the rigors and the timings
No,
of?
initially, no, they didn't. It was
Okay.
difficult for them. But I think over the years, it comes to them. So they also know not to call me when I'm in the OT. So they
It's
never do.
also easier to have a non-doctor husband, isn't it? I mean, because if there are two doctors in the family, then obviously
I
things.
think there may be two
timing-
doctors in the family. As long as they don't work together constantly, that would be okay. If there are two doctors in the family, I would say they take different lines or different fields.
So Keyur is from the corporate side, management, on-show, big tech chap and stuff. Does he ever and you ever discuss economics of medicine?
Frequently.
And what is he? I mean, he must be ridiculing
Yeah.
doctors
He's
as
like, for the amount of hours that we put in, like it comes in the paper every other day. In fact, it's come today. IITs are offering the highest
Yeah, I know.
salary, this, and everybody
On
is so
campus.
proud of that and everything.
So
But our doctors actually expected to work for free. I don't know why this country
I don't. Today I
doesn't
saw this
recognize
day.
merit.
There are
both
no
ways.
charitable malls.
Correct.
There are no charitable cinema
Yeah.
halls. There are no charitable restaurants.
Having
Why
said
are there
that,
charitable hospitals?
So let me. The profession does not choose. You chose that profession.
Correct.
You were aware of this.
Absolutely.
You not walked onto fire barefoot. So my only contention about is that we know what was it and we walked it. She's got two doctors in the family. I've got nobody. Your father was in administration, but I choose to accept it. Do you think it is imperative that some amount of economics is taught at MBBS level?
Yeah.
A subject, Vishra?
So
In terms of, so we don't know much about finances.
Yeah.
So
Yeah.
most doctors don't know
Don't know
anything
anything about
else
that.
except medicine. I think they've spent 10 years at least studying
Okay.
medicine
No,
to
no,
become
no.
any sort of reasonable
Yes.
doctor. Those
So
10 years.
it starts from
Yeah.
class 8. After class 8,
Yeah,
you
yeah.
decide
Do
you go for
classes,
coaching
yeah.
classes. So you're the time when you should be playing and socializing, growing up. You're just
So they
focusing
should
on
teach
studies.
economics or some.
They should. They should. They should.
Do you
I-
think?
and I think it should be-
Have they started? I think there was some
No, 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 no. Not that
undergraduate
not as far as
level,
I-
some
not as
economic lecture or something.
No.
Also, I think doctors by themselves should also learn other things.
We should learn.
We should learn, no? I mean, we are only in medicine the whole time. We also know others. Most of us know others who are also doctors.
Yeah.
So our world is, you're like in a pond, in a bubble. You know doctors, you don't know anybody else. So you don't know how the other side works. So you don't know actually.
Another thing I must ask you, because I've also spoken to you about career guidance and stuff, and you being a very, one of these
Now he's
hands-on
so
mother.
Dr. Raveshia has read that Tiger Mom and
No,
Pop.
no, no.
There's a book like that.
I know. So you're a hands-on mother. I
Yeah,
tell you why
very
it is.
much.
Very much hands-on mother. And Krish is in Berkeley, and I think
Kiara is in 12th.
Kiara will be going to one of the Ivy Leagues.
No.
She will. I mean, she can qualify for going. I mean, she's got the good marks, and she'd probably go. Or otherwise, Kiara won't send her if it's not Ivy.
Yeah, that's true.
Okay, that's. What does it take for a working mother, and how does one? Because now, with younger children going abroad, career being stuff, how do you sort of, how as a mother would you help or advise some young mothers how to sort of look after a child's career, how sort of, because both of them are in Reliance, both of them get 48, 49 or whatever that IB scores, and they are these top part of the problem is genetic. I can understand you and K.
No, but I
But
will
there's
tell you.
always
So I'll tell
somebody.
you. So when both my children were young, I can tell you that the one thing I set for them was a routine.
Okay.
I think
Discipline.
holding to routine is very important for them also. So because I was also out of the house half the time, there were many times when they were alone at home. I think a routine helped them to mold their day, or they knew now that now is I have to do this, now I have to do that. Simply because they've been doing it since they remember.
But what
And
about your how much role does the parent play in sort of passing on information, guiding
in the
them in
initial
career?
few years, I think a mother's role is critical. I feel you can guide your children the best. So my kids never went for any tuition or anything, and I can tell you, I have taught them extensively.
You have taught them.
Yes,
Okay.
I have
Spend
actually
time and
spent time
teaching them.
teaching them. Also, with because my timings were not certain. Yeah, it
So
was. I
you took
explained to my
extra
children
effort.
that, yeah, that whenever I am free is the time you will study. Because
So I think what you're trying to tell us is that you have to have a discipline and routine.
you must have a routine and you must stick to it. I don't mean to do it every day. You can give him every weekend off or every once in a while when you're bored. You cannot do this endlessly. You can always take a break. But by and large, I feel stick to a routine.
And
And I feel most children or most parents or most mothers I meet who ask me, most of the children you see, they are afraid to do maths.
I know.
I
I was. That's why I'm a doctor.
So was I. But I feel like that the only subject that I have taught my children is English and math. I have not taught them anything else.
Wow.
And I have told my children that don't bore, stress over all the other things. It's okay if you don't.
But you're good at maths.
I wasn't actually. I've done medicine. But I think current textbooks, if you want to be able to teach, I think you have excellent books in the market which you can read. I mean, if somebody had taught me either way, I have self-learned now while teaching my children. I would have done engineering and I would have been amazing, yeah.
Earning good amount.
I mean, like, I feel
And why have they
to
not,
remove the fear of maths.
but why have they not taken the medicine? Either
My
of them?
children, they don't particularly like bio at all. They entails a lot of mugging, according to my kids. They just for their life of them. My son cannot mug anything in the world. It's just impossible. So he does badly. By the way, he only does well in Assam, but he also does badly in all languages and in bio.
Mishra ji, you've been a very hands-on father, and I think we heard that Chimmy had asthma, then because of her asthma as a child, you shifted to, you're a very doting,
Oh,
Yeah, but-
absolutely
Dad.
doting
but
father,
I'm not
doting
overpowering.
grandfather.
No, you're not. I know you're not. And you've now got a granddaughter.
Yeah.
How does it feel to become a grandfather? I mean, you I mean, I know from the behavior there's nothing that we can make out, but how does it feel? What is a grandchild to you?
Oh, she's amazing. Mischievous as hell.
How young is she?
2 years. She's mischievous as hell, adventurous, and my daughter is always running after her. Internet, her TV bit, let her fall. She'll learn. She'll become tough, and she's so loving.
Okay.
Really makes all that difference when she comes to you and kisses you. That's
Wow. So all the life effort boils down to one grandchild. Sure.
So as a parent, I think you need to be strict as well as loving.
Yeah.
But as a grandparent, you can just leave the strictness to the
You can just let it spoil. Chimmy is in Pune and she is also in pharmacy and pharmaceutical.
She actually did the MBA in biotechnology.
Okay.
Now she is in a corporate pharma company which, among other things, does forecasting.
Okay.
Which is what drug is
Will
going
go on,
to
which is
be
what it is.
in 15 years time, 20 years time. So what they advise companies about what drugs to focus on.
That's amazing.
So that's lot of.
Son is in.
Son is in
America.
New York.
Okay, and he's settled there.
Yeah, more or less, yeah.
More or less settled there. Any sort of last words from both of you to, one, we spoke about young anesthetists, but I think more important from your side to the general public who are actually have got myths of anesthesia and what they understand of anesthesia and what they should make themselves fit for anesthesia. I think what one thing I'm trying to tell from the podcast and stuff is that the patients also should have a responsibility towards their health. It's not always the doctors. So, what should two things, three things you would advise a patient before undergoing anesthesia? What they should do?
Walk.
Yes, in front of me.
Walk. Well, it doesn't matter if you walk slow, walk fast, but walk every day. If you're smoking, quit smoking. At least try to quit smoking. Smoking is only and only harmful to you. So I would say these are the two most
Two
important.
months. What do you think, Mishra? Lose weight
Yeah,
or
for tolerance, yes.
Yeah.
Walking, climbing stairs, whatever. Even if you climb just one flight of stairs, that's good enough. Because that really does increase the tolerance of your anesthesia, makes it easier for us when you're trying to take them out of the anesthesia. Because then your body has to do everything on its own. Smoking, I don't take.
I think losing weight.
Losing
even
weight,
if they,
yes,
even
yes.
if they lose couple of
So-
kilos of weight, no, I think the recovery
But I
I've
feel
seen
losing
I
weight
think
is much
it's more important to be physically active.
physically. Yeah. I think it was just wonderful talking to both of y'all. I think there are a lot of things I realized I didn't know that you've learned maths. And it's a pleasure, I think, to think.
It has been a pleasure talking to
Because
you.
just the time for two people, I think, should be 1 hour 50 minutes. But then
No,
we
I
know.
think in fact I told Pinky cut down our podcast to 20-25 minutes because
No, I
the
think-
new generation won't
Yeah,
No, it's
cannot
not-
listen to anything. Neither
we
can
not
I.
we not worried about each other. It's like we are having a good talk, and if they want to listen, it's not for it's just to know.
So Pinky can just put a camera outside the OP and we shoot for a session.
Our actual sessions that we have in the operation theater would make very good podcast content, but then there'll be beep a little bit going here and there. So thank you all for watching this, and I must thank Shital and Mishra for being here and letting us know about anesthesia. If you like this podcast, please subscribe, like,